Good afternoon. Welcome to session S16.
I would like to start by acknowledging country. I would like to acknowledge the Aboriginal and Torres Strait Islander peoples and the traditional owners of country throughout Australia and New Zealand, and recognize their continuing connection to land, water, and community. I pay my respect to them and their culture, and to the elders past, present, and emerging. Thank you.
First of all, just some housekeeping. Can I remind you to switch your mobile phones to silence, please? And also, if you want to see us back next year, can you remember to do the feedback at the Congress app? And lastly, if you've got any questions to ask, please use the app as well. Good. So just let us introduce our panel members. Okay, I'm Jeff Lam, and I've got Deepa Taranev next to me. And sitting next to me, we've got Professor Glenn Goh and from Queensland, and Dr. Craig Donaldson from New South Wales, and Professor Sean Dyer from Queensland, and Associate Professor Heather Russell from Queensland as well, and also Associate Professor James Elder from Melbourne. Okay, so now let us start our session shortly. So this session is a question and answer type. So we'll be showing cases to our panel members, and we'll be asking questions, and hopefully we can all learn from the experts' answers so we can improve our knowledge on the various cases. So we'll start our first case. So this is patient or young infant BB. When this photo was taken, he was between 6 to 9 months old, and he previously saw an optometrist, and he was thought to have a left esotropia, and he started the child on some patching, but mommy cannot remember how long it was for and how often she did it. And the examination was, as you can see here, he's got an alternating esotropia, but we cannot confirm abduction because he was just too uncooperative. Maybe I'll just ask Glenn first. No, what do you think, Glenn? It's too loud.
Infantile onset esotropia. Forced Dolzai maneuver, you pretty much always can confirm abduction. It'd be pretty rare to not confirm that, and that's part of the workup, of course. Congenital 6 nerve palsy is very rare, and it's almost always resolved by 6 months of age. So it's a very uncommon to rare diagnosis.
Okay, can you explain to us how do you do your Forced Dolzai maneuver?
Oh, is hang on to the head and give the head a good turn. Engage. You're not wrenching the head; they don't come off. But it just engaging the child's fixation.
Okay.
And it almost always works. It's a pretty unusual child that you can't get them to abduct using that technique.
Okay.
And get them to follow a target, you'll often fail.
Mm-hmm. Okay. Craig, do you have any other ways you can test the abduction?
Look, a couple of things about this case. First of all, it's 6 months of age, which is right on our borderline of definition of essential infantile esotropia. That worries me just a little bit. I think that you need to make sure you've got some photos, and everyone's got baby photos of a child who wasn't esotropic. If they were esotropic much earlier on, well, then it fits into that classification. If they weren't, they've become esotropic, and it's at 6 months, and the child is otherwise term. That actually worries me a little bit. With this child, the other thing I think about, of course, is bilateral Duane syndrome. I mean, do they have a relative enophthalmos when they're looking their eye, when they're looking towards adduction? And I think maybe this child does. As far as trying to get the Dolzai maneuver, I'm a fan of spinning the child. And essentially what you do there is you tell the parents what you're going to do. You pick them up and you just spin them around you like that. You always ask them if they've eaten first, whether they've just been fed. I've been caught a couple of times with that first thing in the morning, so you always ask them that. And that's an easy way of actually making sure and spinning them around, and you can see whether or not they can abduct. If they can't abduct, well, then you've got to look for a different diagnosis, because although some of these children will have some limitation of abduction, it's usually relatively mild. They usually can abduct pretty well if it's an essential infantile esotropia.
Well, the last time I did that a few weeks ago, there's one thing you have to think about is yourself. As I get older, I almost dropped the baby as I got too dizzy. Okay, but anyway, how about Sean? Any comments from you?
Yeah, like Greg, I mean, look, most likely probably it is infantile ET, and I hope it is. But I do think of a six-nerve palsy. Of course, we need to check the background. We can always talk about it. In terms of the dose head maneuver, I do the same like Craig. I take the child, I spin on a chair. I spin a chair with the child together. So when I spin on a chair, I don't have to carry the child that much. And it's often give you a quick observation whether the eye can be abducted or not. And of course, check the pupil. Make sure there's no afferent pupil defect. If there's something worry there, and I'll be more skewed toward more thorough sort of exams.
Any comments, Heather?
The only other thing you could do to try and see if they're going to abduct is do an occlusion test as well for a bit and see if that can help.
Yeah. How long would you put the occluder on?
Probably at least half an hour, about an hour, and then see if we can get better abduction.
Okay, good. So James, now you proved that he can abduct. What's your next move then?
Assuming we've assessed have we assessed vision yet?
Well, let's say he's seeing normally.
So I mean, you want to get some idea of the vision, and in a child this age, it will generally be steady central maintained.
Which is?
Where is along that spectrum, and is it the same? Is there a fixation preference? Is there a head posture that makes you think they're using one eye more than the other? Are they cross-fixing? And so when you stand on one side, and one thing we didn't talk about with the assessment is the language you speak to different children. Those of us who see children speak at least 4 different languages other than English, and they're babyese, toddlerian, preptarian, and adolescentonian. You need to have those sort of different ways of communicating to people. And with children of this age, it's to pitch your voice up and go wobbity bobbity bar up, and move around and act a fool. And that gets their attention often. So if you've established the fixation, you're satisfied that the eye moves, you've had a quick look at the front of the eye. You normally don't get them on the Hark Street to check the anterior segment. It's generally a pen-light assessment of the anterior segment. And vision, as I said, then I'd be proceeding to a cycloplegic refraction fairly promptly. You can run an ophthalmoscope past them to make sure they've got a nice red reflex, and always check the pupils.
Okay, and after that?
Cycloplegic refraction is my next important step.
And that's within the normal age limit of normal. So what would you do? Or maybe I'll ask Craig first then.
What I would do is, well, look, you're taught to wait until they're cross-fixating and then do this and do that, but really we want to try and correct the alignment of these children before 12 months duration of the onset of the strabismus. That's really what I aim to do. And that generally involves surgery. What about you guys? Depending on what the refraction is, I mean, it'd be very unlikely this being a common esotropia, but what do you think?
I mean, yeah, I would probably, if everything's normal, there's no hyperopia, I mean, it's a surgical solution. I agree with Craig. I would try to fix the. Yeah.
So how long do we have?
To wait.
To wait?
No. You should try and correct these children within 3 months of onset.
Okay.
Or your stereopsis drops like a rocket. So if you're on good binocularity, and with good binocularity comes stability of alignment, you need to correct them fairly quickly.
So do you, knowing the health system is a bit tied up with lots of long waiting lists, so is this a Cat 1 or Cat 2?
Cat 1.
Cat 1, okay. Anybody says Cat 2? Oh, Cat 1, good, okay. So let's say mommy said, can I think about it? Okay, so you say, okay, you come back in a few weeks, and then this is for you, Glenn. So 2 months later, he showed up with a pair of near to nothing glasses, but with some sticky tapes on the inside corners of his glasses, okay? And what would you say to mummy?
Well, I'd say to the mother, there's no refraction in the glasses. I would say these are fairly useless. There's no evidence that these binasal occlusion is going to help you. And you're running out of time to get a really good functional result. So do I, I don't like giving parents a guilt trip, but I just talk about what the evidence is. And that's what the evidence is, and that's what we think is the best thing to do for your child. And they've got to, it's their choice.
Okay, that's fair. So we all agree there's a Cat 1 case?
Yeah.
Yep, okay, so Cat 1 it will be. So we'll proceed with surgery.
I'd just add to that though, I think there is a role for Botox here, depending on the angle. I mean, his angle looks pretty large, so I would go for surgery, but if it was less than 35 diopters, I'd consider Botox.
Okay, so if we were doing Botox then, okay, now how long do you think Botox will last for this case?
We're looking for it as a single treatment, so it's not for repeating it.
Okay.
If you
so
repeat it, I would normally like to go for surgery. So if it wears off and the eye goes back in, then I would
okay.
do
So
surgery.
originally, I think the San Francisco report said that some kids can be cured by the Botox too, isn't it? So in one sense, you're going to do Botox under general anesthetic. So why waste the general anesthetic and go for Botox?
It's quick, so it's a much quicker procedure.
Mm-hmm.
And then if it does fail, you haven't done a surgical procedure, so you're going back on virgin muscles, and there's no guarantee your surgery is going to be straight on one procedure either. So I don't think you've lost anything, apart from a bit of time, because the Botox is not an immediate fix like the squint surgery will be. So you're likely to get an overcorrection initially and have to patch through that.
Okay, fair enough. Sorry.
Glenn, what are the points you would include in the consent when you book someone for surgery at this age?
Oh, just I don't think there's any particularly unusual things about giving the consent.
Do you think one surgery is going to fix the problem?
Okay. You always have to tell parents there might be more than one surgery. But if you do, I think the point here is doing adequate amounts of surgery. And if you look at the sort of literature, you do about 1.2 operations or something like that if you do them before 12 months of age. But if you believe all that stuff about the sensory aspects of delaying the surgery, then you have to bite that bullet. But I think you should always tell people there's going to be more than one operation, and tell them there's going to be another operation sometime in the future. At least 25 or 30% chance your child's going to come back sometime to have another operation, either when their obliques begin to overact further down the track, or the long-term trend towards consecutive exotropia with infantile esotropia, and that curve just keeps going on and on, quite possibly indefinitely.
Yeah, thank you.
Let's have another different scenario then. Let's say if he's not alternating, but he's got a left esotropia. And when do you do the next surgery then? Maybe, James, when do you do the surgery?
So this is, you cannot confirm abduction.
Can confirm abduction, but just a left ESO rather than alternating ESO. Are you rushing into surgery?
I tend to do patching. If I think they're amblyopic, I would do some patching and review in a few weeks, 4 weeks or so, and see how they're getting on. I still want to operate on them early. It's a bit debatable. Some people would say the most important thing is the motor alignment, but normally I would patch for a while. And I think the evidence for stereopsis is sort of 3 to 4 months from the onset. So if the child's 6 months of age you could do some patching for a few weeks before you operated.
Okay.
I would commonly do that, but I'd still be planning to do early surgery.
Good.
Would it matter if the child had a mild developmental delay?
It's a slightly different discussion in terms of, it's difficult to know about a child of 6 months of age with developmental delay. That can be a tricky diagnosis. But in general, children who, if you have developmental, neurodevelopmental problems of cerebral palsy, other acquired brain injuries or associated with syndromic things, they tend to have poorer motor responses to our surgery. You have a higher rate of consecutive deviations and things of that sort. And so it's really more a matter of the consent. With children, probably older than this, that have significant developmental problems also, it's a matter of where it fits in their general management of their entire condition and where their parents' appetite is for intervention. Sometimes children with developmental problems will have PEG, they'll have feeding problems, and things like that. And so the parental appetite might be different. So sometimes you have to sort of reset your aims in that situation, as well as warning them about different outcomes. I think if there's something else going on, you tend to have to customise it. You certainly have to customise the consent process.
Can I ask a question? When you're going to do a recess resect on one eye versus a bilateral medial rectus recession, is this the kid that you're going to do a recess resect on because you can't be absolutely sure of their abduction, a bit of abduction weakness, or is it going to change your mind?
Not a lot. I seldom do unilateral surgery in children.
Yeah, me too.
I almost always do bilateral surgery. There's a couple of reasons for that. One is it's simpler, quicker, and heals quicker, and I think that's a benefit for the child. The other thing is if you've got some uncertainty about restrictive strabismus of some sort, in general, you probably shouldn't have planned to resected a lateral rectus if it might be a Duane syndrome. You generally do recession surgery or transposition surgery. So if you suspect it's restrictive, the general counsel I would be is you would delay. Again, you've got different aims in mind there. But I would, the main time I do unilateral surgery is where there's significant amblyopia in one eye. And from a logical point of view, the parents want you to fix the eye that they perceive as broken and they know it doesn't see so well. But even at times in that situation, you're better off splitting your surgery. I had a patient last week who has poor vision after infantile congenital anomaly, persistent hyperplastic primary vitreous, persistent fetal vasculature. And that child had a large ESO and a large hypertropia. If I was to address that with unilateral surgery, I would have had to do a recess resect and a vertical, and that was going to be 2 procedures. So I had a consent with the parents to say, well, even though they've got one good eye, it's perfectly safe to do bilateral medial rectus recessions to address the horizontal deviation, and we'll recess the superior rectus. So you probably prefer, child, you could operate on 3 rectuses in one go, but you probably prefer not to.
Okay.
So, sorry. So this child has a very large esotropia. What is the maximum amount of recession would you do?
For bilateral medial rectus, I wouldn't do more than 6 millimetres.
Okay.
Glenn's got a very nice paper in our local journal on 3 muscle surgery for large angle esotropia, and I suggest you follow his recommendations there once the deviation goes beyond 60 prism diopters.
I would consider, if it got beyond that, doing this maximum bilateral medial rectus augmented with Botox.
Okay.
Save doing a third muscle at the initial first operation.
Good. Sean, what's your maximum?
Yeah, I would do actually, talk to my fellows, anybody. At least beyond 45, I do 3 muscles. I don't like a BMI more than 5 because when you do adult strabismus, you find lots of consecutives, and at age 40, they are going out. If you need more correct, more than 45, 50, really, you need to add a third muscle. Third header. I don't like the concept Botox because I like certainty. I don't think Botox give me the certainty. And I agree. I mean, it buys time. And for kids, also the issue of ptosis, amblyopia. I know if you a master of Botox injectors, you may not induce ptosis, but most induce some sort of ptosis.
I agree. Most will get some degree of ptosis, but not to the point where you're going to get amblyopia.
Sure.
I've only caused 1 total ptosis. I've been using it for years.
Yeah, 6 millimetres, but it's a mixed bag. I mean, some of these kids have inferior oblique overaction, so do you work that into your calculations, add a little bit more because you're going to get an ESO shift by doing your bilateral inferior obliques? Do you wait for that? So look, 6 millimetres, I'm happy to do that. And most of these children that you see with these infantile ESOs, that they're not 60 to 65 or 70 diopters. Most of them are around about 40, 45 diopters, so most of them are actually treatable. I'm interested in again, reminding us about your 3 muscle surgery and the risk of consecutive exos.
Well, if you look at the famous paper that I did with Michael Forrest and Mark Donaldson. And the subsequent paper I did with Jane Camilli, the first paper had 6 years survival curves. So it's about, I have to go back and think about that, but it's about, 75% are still straight 5 years later. So I think, I don't think 3 months has got a huge rate of consecutive exotropia, but all this goes down to how you measure the squint, and you must use your table of numbers and you hold your prisms and have a standard technique for measurement that your orthoptist and you all have the same, you're all on the same sheet of music for measurement, so you have consistency, and your table of numbers should be based upon the way you measure it and work that out, and then you won't get the big weird over and under corrections.
Fair enough. Okay.
Thank you. While we are talking about surgery, we'll move on to the next case and discuss surgery in an adult. So we've got Gary, who's a 52-year-old carer of 2 autistic children, and he sustained a polytrauma in a motor vehicle accident. And this was 6 months ago, involving head injury as well. So he's now presenting to us with bilateral complete 6-nerve palsies and total loss of vision in his right eye. So this is his examination findings. There's no perception of light in the right, and he's got good vision in the left. He's hypermetropic. He's got total pallor of the right optic nerve, and there's a little bit of pallor on the left. So he will need OCT monitoring as well. So keep that in mind. That's the orthoptist assessment. So he's got a large angle esotropia, as you have seen, with significant abduction deficit. These are his 9 positions of gaze, and Gary's question to us is, can you make me look better, and can I move my eyes like I did before? What would you do, Craig?
Oh, we can make him look better, but we can't put him back the way he was. I mean, we can't return his vision, obviously. And the thing that's driving, I wonder what he's next doing, because if he's got an abnormal head posture, it's his left eye that's driving that. So you'd have to do something to that, but otherwise you'd need to do transposition surgery to his right eye, certainly with an augmentation suture, because it looks like there's no function at all of the lateral rectus on that side. And on the right-hand side, he probably does have some movement there, doesn't he? So you could do a recess resect of that if you wanted to, if he wants you to touch his good eye. So I think we can improve him, but we can't fix it.
Okay. Any of the panel members want to add anything else? How else would you check his lateral movements? If there are any residual lateral movements? Is there any role for non-surgical option?
Look, I mean, I say what I just say. I know Heather will say what she would say. Look, I like Gregory's Craig. We can make him better, much better, but I don't think we can make him normal. And I will lower his expectations. But again, he will probably need the surgery to be done on both sides and to make it straight in primary. The good thing, easy thing for this patient, he has no double vision potential because one eye is blind. Easy for us, actually. And but I will be happy either way.
How long would you wait for Botox then, Heather? How long? When would you do Botox? Do we say?
I would have done it already, but it'd be 6 months.
Beyond 6 months, would you consider Botox?
I mean, I think there's potentially a role for Botox for managing his left eye because he has some residual function there, and you could get him straighter potentially without needing any surgery. So eliminate a need for a head posture. I don't think Botox is going to do much for the right eye. Sorry, I think there's a role for it in the left eye to get him straight.
I did Botox in the left, and it didn't work.
It
It
didn't
looked exactly the same.
Did
Yeah.
But Botox is not going to
How
fix
much
it
should you
anyway.
give?
Botox is not going to fix it. It's going to last a little while, and then he's going to be back where he was, wanting more Botox. And so he needs an operation. If he wants to be fixed, he needs surgery.
Well, I mean, Botox, I think, is pretty useless stuff. Sorry, Heather. I think it's useful for consecutive esotropias after exotropia surgery, But I think in his acute phase, this might have been one place for some Botox in his left medial rectus, so he didn't get a contracture. So Heather, I'll be on.
I would have done it already
Yeah,
while
yeah,
he
I-
had this, and
look-
we're waiting on some recovery. So I would have done it months before.
Look, it pains me, Heather, but I agree with you. I probably would have had some Botox into his left medial just to keep him going until he waited for recovery. But he's in for a big amount of surgery, this guy.
Yeah.
All right. In addition to that, he's now wanting to ask you, can I drive? Is he allowed to drive?
Yeah.
Any neurological conditions? No.
No. No.
Do
He
we,
meets all the driving
Fields,
standards.
okay.
do we hear about his fields? He has
His
temporal
field was,
pallor
yeah,
in his
I
field.
showed the field, yeah, there was,
Oh, okay. I missed that. Okay.
And make sure he's not
it's
driving commercial vehicles.
He meets all driving standards
not
for
commercial,
for
isn't it?
personal
Yeah.
driving license.
Any of our orthoptic colleagues here do the driving assessment? Sorry, can't see you. Do you take into account the head face turn? I mean, the severe marked face turn, would that hamper the driving ability? What do you think then? I can't see up there.
Can't see any hand.
If he's got a severe face
So,
turn.
someone like that may need some extra mirrors fitted to their car. So people who have head postures and unilateral loss of vision, there are some orthoptists, some occupational therapists who do in-car driving assessments and can help people with that. His difficulty with a big left turn is going to be doing the centre mirror check, because he's going to have to go like that to see the centre mirror when he's driving. He's going to have to go way around like that. You know, it's not so hard. He straightens his head and he sees the side mirror. And also sometimes other mirrors give slightly wider field of view. So I would be suggesting that may be some benefit. The other thing with that is how long do they have to wait? Because this is an acquired visual loss, and there's I forget whether it's 6 or 12 months that you meant to. 3? Is it only 3?
it's 3 months.
Oh, right, okay. I wasn't sure how long it was. These adults, they're strange things. They're parents of the patient.
Well, it's suggested.
I mean, he's got loss of vision in his right eye, and that itself is stopping him from driving for 3 months. That's one. And the second thing is his field of vision. He's got full field of vision on his left eye, so he's allowed to drive as per the standards. But the practical problem is he can't sit on the field machine with his head well centered, and the same problem with OCT. So there's another indication where I think we may have to do surgery to make his eyes stay in a better position, that you can actually monitor his eye well.
Can I just ask, Steve, when you're doing that testing, is he required to be looking straight ahead when he's doing his field?
Yes.
Because that's his real life head position, isn't it?
Yeah,
And so therefore his temporal field may be restricted
yes.
in that circumstance, because you've got to go around like that to do the test.
I don't think there's any specification in the
Yeah,
driving
but
standards
maybe
about
there should be.
the head, but there's not. So
There's not. The only thing that's there in the most recent guideline is if there's diplopia outside 20 degrees from fixation. And I mean, you can look at him. He's definitely less than 20 degrees from center.
But he does have
it
diplopia.
doesn't have
He doesn't have diplopia, and that's, I mean, he's lucky. Yeah, he's lucky. But if he was having diplopia, he had vision in his right eye, he wouldn't be allowed to. So we just wanted to bring this point out to everyone that bilateral 6 nerve palsies, a lot of them resolve by themselves, traumatic ones, but some of them don't. But keep in mind that adult patients have different needs, and we got to make sure that we ensure that they can live their life with the requirements, driving, etc. Let's move on to the next case, Jeff.
Okay. Okay, so Kelly's 4 years old. He's got 2 years history of strabismus. He's seeing pretty well unaided, 6'9" unaided. And he has seen an optometrist and was found to have a refraction of plus 4.5 both eyes. And his eyes are straight with glasses on, but when he has his glasses off, you can see as in the 9 position of gaze here. Maybe Xuan, you want to comment?
Thanks, Jeff. Look, just look at the photos here. Obviously, he seems to have a full abductions, and however, I just feel to the left, seems maybe the left inferior oblique slightly erective, but with his glasses on, he's straight. I would really probably press on, keep him on glasses because that's obvious the treatment of choice. I know some parents, kids don't like glasses. I see well, but can he sustain? You often test me in the office, say, well, check the vision chart without glasses. Yes, they say 6'9". With glasses, they may say still the same or slightly better, but how long they can sustain without glasses for reading? I think that's critical. And that often may convince them glass is the way to go. But look, I will sit tight, basically push for glasses.
Okay, so a few years later, he's engaging in all sorts of physical sports. And Mummy comes to see you, Heather, and say, oh, the coach would not allow him to wear his glasses when he's playing sports. So what are the options?
So you do get good sports glasses now, and you see more and more kids wearing them. So they can't be stopped from wearing sports. I would encourage sports glasses, the wraparound style that sit actually on the face, so that if they're taking a ball to the face. But depending on the age, if you're only saying it's 2 years later, you could discuss contact lenses depending on the child.
Okay, good. And James, he does not like the look of those sports goggles, so he's lost about 10 pairs so far. And do you trust him in contact lenses?
Look, you could. It's an awkward age to introduce contact lenses, but you'll get the occasional child that will. The parents have to do most of it. I wouldn't be pushing contact lenses, but if they wanted to try it, I've got some optometrists that look after young people. I'd send them to see. I'd sort of counsel them that they're in a hard place. There's no easy answer. You know, he could probably play sport quite well without the glasses if he's not being teased about the appearance. A very rough rule of thumb, and I include this in the first discussion with these accommodative esotropias, is if the first pair of glasses you need is more than +3, you probably will not grow out of them. If the first pair of glasses you need is less than +3, you may grow out of them. Very rough rule of thumb. There is a little bit of literature to support that. I forget where I read it, but it's quite some years old. So I have that discussion with them. I discuss contact lenses and sports glasses and playing sport without the glasses. Sympathy and empathy, but say they're doing the right thing with the glasses. I'm not going to be pushed into operating on children like this.
Okay, well, Glenn, unfortunately, he would not wear his glasses playing sports or his goggles, and he's not willing to try contact lenses. And he's been teased on the field. And Mummy comes to you and say, Dr. Goh, can you operate? I've got health insurance, I've got money.
Well, I've paid my mortgage off, so I wouldn't be operating. You just got to sit down and go through the parents again, because these are the kids, if they're perfectly straight with their glass on at near and distance, you shouldn't operate on them because they will get a consecutive exotropia sooner or later.
Okay.
Also, that's a pretty significant hyperopic refractive error. And we do know that children who are more than about +4 can have problems with reading and learning at school. And kids with those moderate to high hyperopia don't do as well at school and have real problems with literacy. So this child actually needs the glasses to see with, let alone to stay.
Oh, he's wearing his glasses, just that on the playfield he's not wearing them.
Well, yeah. Look, you can put pilocarpine drops in if you like, but it's got its side effects too. I think you just got to sit down and talk to the parents about match their expectations with the reality of their child's condition.
Okay.
And the motivation of the contact lens wearer is the biggest single factor in contact lens success. If the child really wants to have nice straight eyes and wants to play the sport, you know, I don't think there's too many who fail with contact lenses, but the key, as James has pointed out, is having a good optometrist who can fit children. who's comfortable with fitting children.
All right. 2 months later, dun, 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 Dr. Donaldson, give me a prize. Can you operate?
Look, a lot of it, I think, is explaining to the parents what's going on. They don't know what's going on. All they know is that their child's got these thick glasses that they can't see out of, and their eyes are turned, and if you just fix the muscles, won't they be right? And that's, as I teach my registrars, I said, what I say to parents, I said, look, children's eyes turn in either because they've got a focusing problem, a muscle problem, or both. Your son has a focusing problem. We know that because when his focusing's taken care of, his muscles work perfectly. If we were to operate on his muscles, that wouldn't take care of the focusing problem. And they sort of get that. So this kid wants to wear his glasses because he can see better. And most children who have got that sort of script, they'll wear their glasses. They like to do it. He's too young for contact lenses. You're not going to think about refractive surgery, or that has been done in some children. I think that would be a real mistake. Would you implant cameral lenses? No. Would you do refractive surgery? All that kind of thing? It's been discussed. People talk about it. No, of course you wouldn't. What you would do is that you would just counsel them, look, he's got to wear his glasses. Now, the other thing that they worry about, but he's going to lose his stereopsis. He won't be as good as the other children. With his ball sports, he can't see where the ball is. Well, this is when he's not wearing his glasses. Look, most of the sports where you can't wear glasses, the physical sports like rugby, AFL, soccer, I know, is, because I used to be involved with this, it's up to age 10. Up to age 10, you can wear normal glasses playing soccer. It's a contact sport. But if you're playing golf, if you're playing squash, you're playing tennis, all those sort of things, there's no reason why you can't wear his glasses. So this is actually a small group, and it's usually the rugby, the AFL players that have the real issue. And most of the time, they really just, suck it up. But I would not operate on them. I know that in Europe, there's studies where they operate on these children. I think that's a mistake. And I think that these are the children who have a much greater chance of becoming exo later.
I agree. So anyone here will operate on this child? I've got money.
Actually, at Westmead Children's, we got taken to the health care complaints, the whole department, because there was a child there whose parents were insistent that they have surgery. And they'd been in the country for about 6 months, and they were insisting that they have their operation. And the father was extremely hypermetropic. And eventually, the patient's father couldn't find a lawyer to represent him. And we all had to go to court and explain what happened. And the judge ruled that this gentleman had had his day in court, and now he would pay for it.
Fair.
Oh, lots of expenses.
Lots of expenses.
Well done.
Yeah.
Well done.
Good.
But again, it's trying to explain to parents really what's going on.
Fair enough. Good.
Well, here's someone who's had 2 previous queen surgeries. She's had 5 millimeters of BMR, and then her eyes were still turning in, so she ended up having a second surgery, and the surgeons re-recessed the medial recti by 3.5 millimeters. That's what she looks like. What do you think is going on? I think Glenn just mentioned something.
She shouldn't have had that.
Yeah.
Sean, what do you think?
I mean, obviously, I think I've done too much.
Yeah. So what's too much?
We did ask that question.
Yeah, that's a good question. You need to tell me what's the measurement beforehand. I think it is very interesting because we often run fellow advanced cases for this kind of thing. So my take-home message for this kind of initial surgery, we jump into surgery too soon without actually masking exactly how much the eye turned in beforehand. Now, therefore, you plan a surgery over Q. Sometimes you end correct. It's just because you didn't grasp the measurement beforehand. That's the first mistake, of course. And now, of course, the situation worse.
Her refraction was +6 in each eye.
And was not corrected.
Yes.
And was not corrected.
Not corrected.
Well, there you
So
go.
this is what happens when, what Glenn said previously, if you don't refract properly and correct full accommodative error,
It's not rare.
end up into surgery. It's rare, but it does happen
No,
when
this is
people
not
don't
rare.
refract.
This
And
is
if
not
it-
rare.
yeah.
And then you've got a real problem because what you've got to explain to the parent, now look, I'm going to make your child cross-eyed by doing more surgery and they're going to have to wear thick glasses. And that's a really hard sell.
Yeah, but again, +6, they're going to be struggling, just to see.
So Sean, what's your protocol for refracting children with esotropia?
Refraction, well, I mean, look, full complete refraction, at least 45 minutes. I normally ask I kind of don't have the patient to wait. I give everyone everything, okay? 1% tropicamide, 1% cyclogel, plus 2.5% phenylephrine. So all 3 drops all on one go, so as a good weight. So I would say 95%, they all be fully sarcoplegic if you have 3 drops all in. And if the obvious have a hypermetropia, as we discussed before, anything slightly before above 2 or 3, I definitely give glasses a try first before I talk about surgery, because what you show here is clearly we have done surgery with something not require surgery. I would concur Craig's observation or experience. I'm from the other side of the ditch. By no means I'm criticizing Australian colleagues. I certainly see a lot of patients come with this, have a hypermetropia, but operated before.
Yeah.
Yeah. So I think something we really need to go through the step, check refraction, give glasses, nice surgery, not make the parents happy just jumping and say, I operate on the eyes, the eye looks straight, and then they end up with this.
Look, can I ask a question? Because
Yeah.
I don't know where you get this magic number for reassessing the medial recti from.
Exactly.
I'm not, and I will stand corrected, please, if there's some magic table somewhere that tells you.
That was what was written in the operative notes. I inherited this
Hold on,
patient.
You're suggesting they knew what they were doing?
Well, that's true. Let's ignore the refraction. But of course, if you do bilateral surgery of the medials, your next operation is bilateral lateral rectus resections, for which there are tables of numbers. So double jeopardy here.
Yeah.
There's a possibility the person actually not uncommon when you go in. They say 5.5, you find it in muscle at 3 millimeters from the original insertion. It may well be the surgeon just teasing the eyes, did whatever it is, think it's 5.5 or 5. Well, it's hand back, whatever it is. The muscle actually attached not there. I mean, in that situation, they may have done some recession media. I agree with the formula. I don't know from where to get formula, but
I'm not
it's
aware.
depending on what they find when it's opened up, I suppose. Yeah.
That wouldn't have been your first choice, would it, for a reoperation for a residual?
Sorry?
It wouldn't have been your first choice to go back and re-recess.
Definitely not. Yeah.
James, you had
With the management of this child, I suggest we've actually moved from the simple to the very complex in a sense, because if they're significantly hypermetropic, as was mentioned, they're going to need the refractive correction. I suspect you're going to measure an exotropia there, potentially, 60, 70 prism diopters, maybe something of that order. The other thing is if they've been out for a long time, they're going to have some contracture of their lateral rectus. So when you do operate on them, you'll find forced duction, it might be tight. The other thing is reoperation on the medial rectus is a risk factor for getting a stretched scar and a pseudotendon. It's got a pretty marked medial rectus underaction on both sides. So as well as physically having the muscle in a very irregular place, it may not be adhered to the globe normally. And so in an ideal situation, you'd be planning to do an adjustable suture procedure with a child like this potentially, which you can't in a child of this age. This may be one of the odd situations in which you actually put the rectus back almost where it started, almost back at the old insertion.
That's what I did.
Yeah, because you really sort of need to go back to the start and see where it is. And so is that what you did? You put it back at 5 millimeters from the limbus? Yeah. The other thing to say, just if you're planning to do this surgery, this is a really good case to be able to do a fornix incision, particularly with reoperations, the conjunctiva scarred, particularly if they use the limbal approach. And so you wouldn't, as a general rule, try and use a limbal incision with a reoperation with the muscle being operated on twice before.
I would.
I would.
Yeah, me too, because
See what you're doing.
Sorry?
God,
you're making life very difficult.
You started the
a reoperation like this, if they've had a limbal incision, involves potentially 20 minutes of dissection getting everything off the sclera because it has healed back on. Whereas if you do a fornix incision, it's 5 minutes to find the muscle and then a few minutes brushing it back, and it's not a long operation.
Sometimes you just don't know where the muscle is. And my philosophy has always been you start the limbus and work your way backwards, and sooner or later you've got to hit muscle. Whereas if I'm in the fornix, I could be right over the top of it. It may be in front of me, behind me. I don't know where it is. And there's often a lot of scar tissue.
We'll have to disagree.
I'm the middleman. I'm sitting in the middle. I have done both. And I think I take James' eldest point of view because there's one thing in young kids, you certainly can do fornix incision even for reals because the conch is so stretchable. But the same can't be said for adults. You're going to cause a mess there, actually, not only find muscle, but cause lots of bleeding toward the conjugal part. You can't actually cover your muscle afterwards. So I think both are possible, and it depends who the surgeon prefer what you do, really.
Well, I do phonics only, so I can say that the phonics in scarred cases will gradually migrate and becomes a liposuction. So actually, it's both in the same case.
Can we just go back to Richard pre-op?
Can we go back? Good.
This child looks to have an X-pattern exotropia, which with these eyes flipping, the superior and inferior obliques flipping over the globe. And this would suggest to me, like I think James suggested, there are tight lateral recti here. So I think great result from what you've done.
At the time of surgery, she didn't have tight lateral rectus.
Okay.
So I just advanced her medial recti. She still got inferior oblique overactions bilateral. And I've left it at that stage.
So we don't know what the ductions are. You've shown the versions, and you're saying there's underaction of medial rectus. There may not be at all. We just don't know what the ductions are here.
And the forced ductions were free, so...
Well, the lateral rectus is probably fine.
Diva, how easel is she without her glasses?
Without her glasses.
Is she easel without her
She had a variable ESO from the photos that I could see pre-op.
And then post-op?
And post-op, she was XT.
I mean,
after the first surgery, she was still the same. She was still in the variable. So there were various photos. I couldn't get hold of it, but
No, after your operation, when you advanced her.
She's XT actually. She's got a small angle XT, and she's in +2 glasses, even though her refraction is +6. She's got 6/6 vision, and so I've left her at that. But the teaching point here was good refraction, and I think that's very important that we ensure there's full cycloplegic refraction and repeat refraction. If you're not confident and you fail, in spite of wearing full correction, there's still a residual esotropia. There's no harm in bringing the patient back, doing atropine refraction.
And even just repeating the cycloplegic refractions, after you put them into what you find at your first examination, they often relax their accommodation even more. So, you're not completely paralysing them with cyclopentalate, but you often find a bit more on subsequent testing. And I tend to tell parents that when I give them the first pair of glasses that we might be increasing the strength if they're not straight at the next review.
On that, Heather, say if you've got a hypermetropic child who's, say, +4, never had glasses before, and let's say is 3 years or 4 years old, what is your first prescription going to be? Cycloplegic refraction is +4.
And they're straight or not?
Straight.
And what's their vision?
Let's pick a number, let's say 6/12.
So if their vision's reduced, then I would prescribe. If their vision wasn't reduced...
You would, but how much would you prescribe?
I tend to take 1.5 off of it with straight eyes. But if their vision wasn't reduced, well, I think that's a bit contentious now, but whether it's safe to watch those kids and not correct. I think there is some evidence coming out about potentially not correcting these refractive errors if the vision's otherwise normal in that age group. But if the vision was reduced, I'd definitely prescribe. So +3.
Okay, thank you.
Move on to the next one.
Okay, so Ruby is 13 years old. He's got a long history of an intermittent exotropia, I can give you that. And now he's a teenager. He's just not happy with with her appearance. And you can see, but the intermittent squint happens when she's tired or not feeling well. So, Sean, what would you suggest to her?
So I presume she has no refract errors?
No.
Okay. I mean, obviously, we often look at a control for intermittent XT, and basically, I'm going to talk to her about surgery. If more than half of the time the eye is turning out, the other thing I often ask, do they really see double? Some of kids in this age do see double, and they tend to close the eyes outdoors. So those are all soft signs or some evidence they are not used both eyes together. But in the office, I would check, of course, the 3D vision, but I don't find they're that reliable. And now we look at the distance, this still acuity as well as some sort of a better gauge, but again, the experience is still limited. Really will listen to parents, how often the eyes out. If more than 50%, I would talk them into surgery.
How do you do a distance stereo?
There's one actually we tried, there's a commercial one, free space, but we also have the New Zealand version. I forgot the name. Mick is here. Are you here, Mick? What's the New Zealand version? Visitech. It measures both across the 3D disparity, so it's pretty accurate so far experience. So they give us like how you see many kids with intermittent XT trouble is when they look for distance. Therefore, distance 3D vision will give us better objective assessment. Yeah.
Yep. There used to be a machine called BVAT, B-V-A-T, but that's not. I think they've gone broke. Okay. Okay, James, what's your opinion?
Yeah, I would be thinking about doing surgery with someone like this. Because you've got a large deviation. I mean, in essence, she's a 13-year-old with an intermittent exotropia. And so your options with an intermittent exotropia are to live with it, to consider a myopic overcorrection. In my experience, that helps about 1 in 10 children, a myopic overcorrection. You can measure their AC to A ratio, and if that's increased, that may increase your suspicion. That would help. Or you can consider surgery. It's to be perfectly honest, it's a little bit of an odd history to say that it's it's present when she's tired or unwell, and then you've got a photograph like that. So was she really tired, really unwell? That to me looks like a large exo. She was probably fixing it near when the thing was made. So I suspect the control is actually not quite as good as the history suggests. The other consideration, if you're planning surgery, is to do occlusion of Marlowe's. There's some evidence that if you measure a larger deviation after a period of prolonged occlusion, look, there's some debate as to how long that should be, whether it's minutes or half an hour or an hour or so, and so you tend to operate on the largest deviation that you can measure for intermittent exotropias. And the other thing is, in the intermittency, you generally don't need to be fearful about overcorrection. The one case that really brought that home to me very much was a child that I looked after for years who had quite a good result from a unilateral cataract and had 6/12 vision in her cataract eye, and she had an intermittent exotropia. And a parent said, when it's there, it's really bad and it really worries her. And we often didn't see it in the consulting session, and they brought in photos, and eventually we did a prolonged period of occlusion, and she measured about 40 or 50 prism diopters, and was there regularly. They showed me photos, so we operated for that, and she got a reasonable result. Now, she obviously wasn't going to get terribly good stereo because she was had a history of aphakia, and she did quite well. So I don't think, in general, you don't need to be concerned about overcorrecting. You look for the largest angle and operate on that.
Okay. Thanks.
Okay. Move on to the next case.
Okay, so Glenn.
Can I say with these intermittent exos that it's such a mixed bag, and we make everything so confusing in strabismus. I think it's to stop everyone else from doing it, because we really do make it confusing. I think it's really important with these patients to work out those who are good at converging and those who can't, and those who are terrible at it. And those who are terrible at it and can't converge, they worry me because maybe there's some other pathology, particularly if they can't look upwards. I'm thinking about paranos. Those who can converge well, I start them on orthoptic exercises, and I find that a number of these kids do well with orthoptic exercises and they can get what they want to out of it. And those who fail the orthoptic exercises will then surgery. And if they're poor at convergence, then I have to think about a medial rectus rather than just laterals.
Okay. So Glenn, you've done surgery. Next case. And 3 weeks later, she came back to see you with this. What do you do about this?
That looks like a pyrogenic granuloma. So I'd probably excise that under local and give them some steroids, or just give them some steroids and see what happens. Mm-hmm. It's too early. It doesn't look like an inclusion cyst, and it's in the right spot. Who's done a fornix incision? Yeah, I would have done that, and that's what that looks like to me.
Yes, so I do phonics.
If it's a big lump, put some local in, chop off what's there, and then give them some steroids for what's left, or just give them some steroids and wait it out.
Could try Timolol.
Timolol.
Yeah.
Good one.
They work quite well on these now.
And how does it work?
I think it's a bit like the hemangiomas, propranolol,
Okay.
the beta blocker.
Right. Okay. Well, I used steroids and it dropped off after a few weeks.
Right, we'll move on to the next case. So we've got Lily, who's a 13-year-old girl, and she has noticed that her eye appears lazy in photographs, and some of her friends have said her eye behaves very lazy. On examination, she's got normal vision, 6/6 HI, no other medical or past ocular history, and that's what she looks like on 9 positions of gaze. So as you can see there, she's pretty straight in primary, but she's got limitation of eye movements in up gaze, and that's what she's noticing when she's taking selfies and stuff, with her hand held up like that. What do you think you would tell her? What's her management? Heather?
Stop taking selfies.
I knew you were dying to tell that. I knew you were very eager.
It's better taking from up to down, isn't it?
Tell her to take them from down.
Down.
Yeah.
Would anyone consider surgery?
So what is it anyway?
Well, looking probably at the right browns, but again, we're doing versions, not ductions, but on ductions, if there's limitation, well, then that's a right browns. She does have a slight leftover right in left gaze, and maybe that's upsetting her as well. The most I would do for her would be a left superior rectus recession, because that tends to be relatively harmless in the primary position, and it may help her in left gaze, give her some benefit.
Superior rectus recession?
Yep, of the left eye.
What do you mean?
Of the left eye, the
The contralateral eye, yeah.
What about primary gaze is straight?
Yeah, look, doing a superior rectus recession won't do much in the primary position. You know that
How
from
much?
operating DVDs. You can do an 8mm
But it's
recession.
not DVD.
I know, but you can still get away with a reasonable amount of recession of the
But
superior
the
rectus. in the primary.
physiological fusion vertigo is terrible. 2 or 3 prism diopters. I'll be worried actually.
You do it with an adjustable.
Yeah.
Yeah.
You mean recess 2 and pull back 2?
No, I'd just do a recession of a left superior rectus.
You can do one of those recession
You can do a
operation on the
simultaneous
same one,
resect. Agree.
on
Yeah.
the same muscle.
Yeah.
and
Yeah.
Then it won't affect the primary.
But I'd
Yeah.
try and talk her out of anything.
James, would you operate on this girl?
Probably not. I think the indications to operate on children with Brown syndrome are slim, and it's basically if they've got a significant deviation in the primary position or a compensatory head posture to achieve binocularity, which is related to the deviation in the primary position. So it's head posture or vertical in primary is the main indication. So I would be reluctant. I can see what Craig's saying, but I can also then hear what you said a little while ago. We're trying to keep it simple. The deviations in 9 position of gaze here would be interesting to know. I think in up gaze it does look like she has a left over right deviation in both in right and left gaze, and if that's the case, a procedure to weaken the apparently overacting, it's possibly almost a secondary deviation of the left superior rectus may improve some of her selfie symptoms.
Yes.
School of hard knocks. I had an adult who presented with a very typical Brown syndrome, ready, set, go, and she turned out to have myasthenia gravis. And this girl has got very mild ptosis. So I'll be looking for acetylcholine receptor antibodies because how long was the history?
She's had it for a few years.
Yeah, well, it's a cheap and simple test, and she has got a bit of mild ptosis.
Would you still do it if she doesn't have any variability?
Well, this lady was a straight up and down Brown syndrome, straight up and down, and she improved with treatment for her myasthenia.
Okay. I've convinced this girl not for surgery, but if
else.
she wants surgery, I'll send it to Craig.
So would any one of you actually touch the superior oblique in this case?
Yeah, I think I would prefer the superior oblique if I had to force to do surgery. I'm going to do a suture spacer actually on the eye because it's the cause of the problem. I always think we should go to the root of the problem. I know you do a lefty superior rectus recession, it may help. I just worry the trouble you cause actually for primary.
You won't?
Go somewhere else.
Yes.
Go to Queensland.
Craig would do the left eye,
I wouldn't.
do the right eye. Heather, would you touch her?
I try not to touch her.
Okay.
Is it just
If you were to,
Open a can of worms.
what sort of worms?
Well, if you do a superior oblique spacer, you could get quite a lot of complications from that, the
Sure.
Sharon syndrome.
Yes.
So you might just wish you'd never
Sure.
started that. If she's straight in primary, which
Mhm.
there's no head posture, and she's straight in primary, I really try not to do anything.
But there are other options rather than a spacer, though.
If I was going to do something on the superior oblique, and I have done on what was an apparent acquired Browns, but it was a young boy who presented with sudden onset double vision and a Browns, but he actually gave a long history of waking up in the morning and his eye clicking. So he obviously had some sort of congenital anomaly of the trochlear complex, and then it just got stuck. So my first operation was to try and force it. So I took him to theatre and forcibly, Ken Wright, moved it and it alleviated it. And then it came back a week later. I just did the Z-plasty lengthening.
So you did a forced suction test. In
And
other
I
words.
forced duction test
Okay.
and released it in theatre.
Okay.
I thought I'd cured him, but it just came back.
Okay.
So I did do a tendon lengthening, but just did the Z.
Glenn, you want to say something?
There's no superior oblique overaction there. You're just going to get into trouble here, I think. Make trouble for yourself. You push over the first domino and 3 and 4 operations later, you wish you'd never done that.
But isn't it a restriction rather than superior oblique overaction?
Yeah, but if you're going to do it,
You lengthen.
I think long term something's going to come back and bite you if you weaken that superior oblique too much
Okay.
over time.
So
James?
just a general principle when I'm thinking about strabismus surgery is, A, what do I think is the best operation for this particular problem? And the second thing is, having thought about that, is there another option, particularly in the situation where you think maybe I should operate, maybe I shouldn't operate? Is there an operation that I can do that is more reversible? So this is a classic example of that. So if you were to do some superior oblique weakening surgery, so something to lengthen the superior oblique tendon, there is not a lot of going back from that. It's hard to actually go and plicate a tendon if you get overdone doing that. Whereas if you to do a superior rectus recession, it's pretty easy to go back on that and advance that muscle, relatively easy. And so if you are unsure about this, there are some situations, and perhaps we're moving from the simple to the more difficult, but there are some situations where there's not a lot of going back from the operation that you've done. And so sometimes you need to have that in your thinking about how I'm going to approach this. Do I do something that's more potentially reversible if we get an overcorrection? versus something that's more likely to address the problem. So normally if it was a severe Brown syndrome with a hypotropia in the primary position or a head posture, I'd have no hesitation in operating on the superior oblique, and my preferred operation to weaken it is a Z-plasty. To just lengthen the tendon. But in this situation where I would maybe have some uncertainty as to how that would work in the primary, I'd be happy to do something to the superior rectus because I know I can go back on that with less hardship.
Have you heard of the chicken suture?
I used to do the chicken suture. I just think the Z-plasty is more elegant, and you leave some sort of biological tendon where it should be.
Okay,
Thank you. Heather, you mentioned your case, the young boy who had history of popping sound in his eye. He's an adult who has a similar history. He's an electrician, and he complained of intermittent double vision on and off for the last 3 months, again with the same pop sensation in his eye. He's healthy otherwise and has no significant past medical history. So that's a video of his eye movements. And he has this intermittent pain on moving his eye. Right, so this is his 9 positions of gaze. What are you thinking of?
So looks like he's got an acquired right rounds, and he's got pain, so it might be rheumatological.
So what investigations would you do?
We'll do an MRI scan and a blood workup, looking for inflammatory causes and infective causes. I've seen this in a boy post-tick bite. It was a positive Lyme's disease, but we don't have Lyme's disease, so presumably it was a similar organism, and he settled down with steroids. So if you can show that it's inflammatory, I'd give him a steroid injection into his trochlea.
Craig, what imaging would you do?
Look, I do that. I've seen this a few times with patients with nodules on their superior oblique tendon, and I tend to treat them with anti-inflammatories as long as everything else is okay, and with a period of time, most of them seem to get better. I've operated on 2 of them where I've tried to dissect the superior oblique tendon and nodule, and that's been spectacularly unsuccessful. But fortunately, over a period of time, just with force duction, it seemed to help them as well. But I'd be looking for a nodule on the tendon for this patient.
So would you get a CT or MRI?
I'd get an MRI.
Yeah. Any other non-surgical treatment options?
I think I just want to make a comment. I'm not sure we're just thinking is only inflammatory. I think certainly orbital floor fracture shouldn't be completely right off. We presented Spoon Club, this 16-year-old with this so painful look up, end up we found a fracture, in the orbital floor. So I agree, most likely inflammatory, but look, the MRI scan will be the first thing I go to before talking any treatment. The other thing worth knowing is this IgG4, and often have 1 enlarged muscles, so it can be very painful when we move, almost like thyroid, except it only affect 1 muscles. So I would definitely prefer MRI scan to CT, yeah.
Okay. He did have an MRI, and that was negative. There was no inflammatory nodule, but he had pain on examination. He had tenderness at the site of the trochlea. So it's indicating there's some sort of inflammation. What treatment options do we have here, Heather?
So I would give him a steroid injection.
Any role for oral steroids? Treatment
I think it's
trial?
better to give him local into the trochlea rather than give him oral. You can get less side effects, so I would just inject it.
Would you wait, or would you go, he's presented with 2 weeks history now with this episode.
He's in quite a lot of pain, so I don't really see.
On this day?
Yeah.
So Craig, you mentioned force duction test. Can you describe to us how you do a force reduction on a Browns?
Well, first of all, I explained to the patient what I'm going to do, and you can't do it on a child, of course. They won't let you near them. Some adults won't let you near them. Women tend to be a lot better than men because they're used to putting things around their eyes. I then tell them what's going to happen. I explain that there may be some redness of the eye. I use Alkane on the eye, lie them down, put a drop of half-strength betadine mixed in with the Alkane. Then I grab the eye at the 9 o'clock and the 3 o'clock position. I rotate the eye, rotate the eye and then move it upwards into adduction.
And what are you looking for when you do that?
Tightness for Browns, just tightness of the movement itself. Okay. So I'm putting the superior oblique tendon on the stretch and then moving it.
Okay, fair. Can you click on the emoji, please? Okay, so I just happened to present, to have a video of the guidance exaggerated traction test. As you know, Guyton described the force reduction test, so this one's named after him. And this was what he taught me to do when I was with him. And Guyton's original description is using one forceps. So have a look first. So you grip the nasal limbus and you push back to put the oblique under tension, and you flick, and you can see the eye rolling over the tendon. We just do it once more. As you roll out, this is inferior oblique here. So you see it just jumping over the inferior oblique. So after I've disinserted the inferior oblique, you will see it goes perfectly smoothly without that need to jump. Okay, so the traction test basically serves two purposes. One is to check the tightness, as you said. If you have done enough, you sense that it's very tight. The other is actually to see whether you have done a complete myectomy, tenotomy, tenectomy. So it actually checks your surgical result as well. You can click on the emoji again, please. Okay.
This is the same gentleman. I did a steroid injection in the trochlear region, and 6 weeks post-op, he was fine. It's now nearly a year, he hasn't come back, so I'm hoping he's fixed.
Very impressive.
Was there anything in his blood workup?
No, nothing came back. I didn't check him for Lyme disease, and yeah, I didn't go the fancy stuff. So
About 6 minutes. Do you think we can do this case in 6? Or should we finish? Should we save it for next year? Or we can, what do you think? Should we continue?
finish it.
You can
Okay.
make a rapid fire. Yeah.
Okay,
5 minutes.
5 minutes, okay.
So we have a 14-year-old boy who's got a long-standing history of a head tilt, and sometimes he's got double vision. So that's a video of his eye movements.
Can we click on the video?
So this boy presents with his mom, who has done some research on his diagnosis that the optometrist has said. And she wants to know if he should have an MRI scan. Sean?
I mean, the picture here, pupil is dilated, of course, and looks to me like a proper typical fourth neuropalsy on the right, because here's a right or a left, worse with the right head tilt. But of course, you look at torsions, everything. If not everything is fine, and long-standing, non-aligned neurological signs, look at the head shapes, I probably want an MRI scan.
I mean, have a look at his face. What do you want to see here to say that this is congenital.
Look at his face, almost like you can see like a triangle. So the big opening part is pointed to the eye, which is the original problematic eye, because he tilted his head to the contralateral side, he kind of squashed. This is one of the signs often. I find they're quite reliable.
Yeah.
Any old photos?
No, I haven't got them. Does the panel agree we don't need to image this boy? No. Okay.
Well, you would ask for the photographs. Normally with family album, fat scan, they'll look back and see that he has head tilted his whole life.
So what's your surgery of choice, Glenn, to help improve his head tilt?
You've got to work out there how big his deviation is. And you've got to look at his 9 positions of gaze and work out where the deviation is greatest, and then work out how you'll address that.
Yeah, he's got.
I don't think there's a simple formula. One size does not fit all. There's several different ways to go about congenital fourth nerve palsies, and I think you've got to look at how big is he in the primary. Is he more?
He's 30 prism diopters in primary. So what's your choice?
Well, it depends if he's got what he's like in contralateral gaze. At that kind of height, you might think about an anterior transposition. If there's depends how much spread of competence he's got, or you can end up just doing vertical recess resect or whatever to deal with that. Depends we don't know what his inferior oblique's doing. We need more information to make an informed choice.
Okay. Do all the panel members agree with the choice of surgery, inferior oblique anterior-session?
I mean, this first thing I would go to, as Glenn says, really is no one rule fix all. You depend on measurement. You say measure 30 prism diopters in primary gaze. Yeah. I would definitely tackle inferior oblique and the contralateral inferior rectus, because with 30 prism diopters, you cannot fix just by doing one muscle. But fusion range is crucial because you don't want to overcorrect.
I was going to say he's probably got a massive fusion range, so you may well get away just with doing one muscle in him. So though he might
Which one muscle?
Inferior oblique, but you might get away with just doing that because he's got such a huge fusion range.
Yeah. What's James's?
I agree with you need to know what the deviation in the corrected head position to know whether it's 1 or 2 muscle surgery. In general, with congenital fourth nerve palsies, which are really over-elevation in adduction is a better name for them because they're not necessarily a small superior oblique muscle and a true palsy. But with congenital fourth nerve palsies, I most commonly do an inferior oblique recession, and then if you have a persisting significant undercorrection, then I go and look at the superior oblique tendon and would consider tucking it. Some people would suggest that you should do a force duction test at the time to see whether it's floppy, actually explore the superior oblique tendon. If it's a lax tendon, that your primary operation should be a superior oblique a tuck. I haven't done that, but there's plenty of very respectable strabismus surgeons would suggest that's how you should approach them. I generally find an inferior oblique recession, it fixes the vast majority.
So you do a straight surgery, you'll just do the inferior rectus recession and...
I would generally just do a straight recession for a fourth nerve palsy, yeah.
You want to add anything? Craig?
He's got 3+ overaction of his right inferior oblique. I'd do an inferior oblique myectomy. That's all I do.
So quite a few different options here.
Yeah, I think the spread of competence is the critical thing because all your inferior rectus surgery, contralateral inferior oblique surgery, that side, is not going to fix his deviation right gaze. So you do need to address that either at the first outing or whenever's left, because that's what he'll be left with in primary position when you've done all those muscles moving to the left.
Thank you.
Next slide. Can you click the emoji, please? Oh, sorry, go back. Well, anyway, according to our time's up, so I would like to thank the panel for giving us their expert opinion. Thank you. In particular, Professor Goh, who comes out of his retirement to address the cases. And thank you all for your participation. And please put in your feedback, please. If you want to see us again, we'll be back next year with more vertical muscle problems.